First of all, I think to say thanks is not enough. I would like to do my personal applause to the President Emeritus, to Ahmed, and I encourage all the fairing colleagues to do the same, because the organization is really incredible. So please give an applause to all the IGA organization. And now let's start to work on it. My presentation is about the massive cuff tear alternative arthroscopic solution. Let's say, okay, this is my disclosure, and I'm pretty agree with you, Sharif, because most of the things that I will say are quite exactly like you say. The lecture too maybe doesn't fail to us, and we know that there are different kind, and also Mark before, the colleague before said that described the Hellman classification, but about the partial lesion. But the arthroscopic is important, this classification, the SCOI classification, about the arthroscopic repair that is mainly for the 3 and 4 type, more severe rotator cuff injuries and very severe partial rotator cuff. Let's say that we have to focalize our attention to the injury of the tendon, how much wide they are in this massive cuff tear. And Borka introduced the geometry of the classification that is very important to give the right indication for the right exactly procedure. The rotator cuff tear are very common in most cases. Sometimes they are irreparable. A subset of spasm existing from the rotator cuff tear, and retraction is very poor tissue quality. We will see later. The challenge is to choose the better treatment and for this kind of repair. So superior cuff reconstruction in the United States and worldwide, we try in Italy also, we made a pool of orthopedic surgeons that tried to use this technique, and is an alternative to long-haired bicep tenotomy, tuberoplasty, partial arthroscopy rotator cuff repair, and interval sliding patch augmentation and muscular transfer. Have a defect. First of all, they don't have great arthritis, and capsular discontinuity is one of the causes that probably can give in the future also instability. To aim and restore the superior glenohumeral stability is important to restore the superior part. Miata described this technique very smart, and he started with to put the fascia lata or autograph described before the colleague in between the medial part and the lateral side. There are colleagues that describe many variations on that. But Azevedo investigated the outcome of all this, and either the fascia lata and humeral allograft, active elevation, active alternate rotation, as scored, they find all the score, but finally the use of either fascia lata or humeral, they really doesn't give great results in the outcomes. And these are the study with the 26 questions as a survey to many surgeons. After 5 years of follow-up, they say that is really the superior cuff repair is declining as a procedure. So let's say that sometimes in Italy we do also good, we have good idea. So a brilliant colleague from the SCR technique thought that the long-head bicep with this natural insertion on the glenoid can be an augmentation in this kind of cases. So let's see how we can do it. First of all, the indication is for patients without arthritis, conditio sine qua non, the presence of the long the bicep, obviously, and is an all arthroscopic procedure. General anesthesia or otherwise cervical plexus, B-chair position, 3 portal, as we will see it. The bone bed has got to be cleaned and rebuilt as we usually do it when we do a regular cuff repair. The long abdominal tenotomy is performed distally, as we will see later, and laterally fixed to the great tuberosity. We can do it with the 1 anchor and 2 anchors, like described in this case, and or otherwise we can do it with the transosseous tunnel. And as you can see, we have to just move posteriorly this long half of the bicep that is always good tissue autologous of these patients. And this is what happened. We can do it with the transosseous with only 1 anchor. I personally do with only 1 anchor. I will show you later. So this is the procedure. Subscribe and see exactly what we have of scar tissue, and let's say what remain of the superior part of supraspinatus and of the capsula inferior. This is tissue that, if the tension is good enough, you probably will do a tenotomy and maybe a side-to-side with 1 anchor. But why you should leave, you should not use this tendon, even if the tissue is not great enough. Sometimes is good, is better than this. But if you have the infraspinatus remaining tissue, and which means posterior, and some good part of subscapularis, in this case just is the peel-back effect of the long biceps. Once you clean the footprint area, you can do and continue with this. Oh, excuse me. Okay. You can do the lasso loops on the distal part of the long half of the biceps, tear the part of the long half of the bicep, and perform the tenotomy. I personally don't do a tenodesis because I don't think 20% of cases of Popeye sign is not good enough, except that the patient doesn't want cosmetic problem in that case. So in this case, I will put the anchor laterally with a knotless anchor, and I will stabilize posteriorly, as we saw before in the design, the long half of the biceps remaining that still remain attached in the glenoid side. This biomechanically give the humeral head down, but it's not enough. You will see later, because now this is the view from the posterior portal, as you can see in the outside view. And once we do this, we can cut the suture, like in this case, and okay. And then I'm starting to pass 2 sutures of different color through the remaining anterior cuff, the long half of the biceps, and posterior remaining cuff. So I can make the nuts from posteriorly, so the nuts doesn't make any disturb to the anterior part, and I make my side-to-side with the long half of the biceps. This way, encourage and get low the humeral head. As you can see in this case, I put my view from the lateral portal, so I can do my nuts from my classic Duncan nuts from posterior portal. And I start from the medial part first, and then I do with the second suture from the lateral side. And it's as you can see, it's not a difficult technique for who really do a lot of surgery, arthroscopic surgery. And the final result is that you have the human head down, and this is what the CSR wants to do it mainly. And as you can see, you can reach there. I did many of these cases, like 25 cases, and the other colleague, the Kilemi, did also more than 75. Is a new approach for this kind of procedure. And I tell you that gave a good result in outcome. The disadvantage, possibility to have the absence of long head of biceps, anatomy variation, intra-articular portion, and Popeye sign for sure. But the advantage is an autograft without any donor side mobility, cost saving, long have a bicep tendon remaining its original, which means a vascular peduncle. The longer is still yet medialite to upper part of the glenoid, and lateral fixation doesn't present particular skills because really you need to put just one anchor on the lateral side. The review of the colleague, Professor Nicola Maffulli and Francesco Oliva, said they find a review of 17 articles when included in this systematic review. Biomechanical study report a normalization of superior humeral head translation following the procedure, and the use of ipsilateral long graft repair muscle is safe and effective, technically demanding. So also we had augmented repair of large massive delaminated rotator cuff, and Giuseppe Milano do the same even if they have a small tear, which means that you can use your long half the biceps as an augment in this case. And in this cadaveric public is used as scaffold biologically, which means that is very important and save cost. So finally, take-home message is a valuable alternative to restore the humeral head lesion. Correct patient selection is very important, as always, in our surgery. The ABC CSR is safe, easier, time, cost, safety compared to other published technique. And all arthroscopic procedure is something that probably we encourage to use all of you and see what's going on in the next future. At the same time, I like to invite you all in Rome in the next few days, as the colleague says before, for this great Congress that will have 2,000 surgeons worldwide for the 15 Xs made and 7th Xset, and the President Alex Castagna and Stefano Gumina we will all have the pleasure to see you in Rome next future. Thanks a lot.